No thrombolytic agent, only antiaggregant and anticoagulant. Here I have two comments or consideration, maybe questions, I don't know. First, for which reason it was decided to perform coronary angiography on the next day and not immediately? Maybe it was impossible to perform it urgently, no team at duty, problems with the equipment or other some reasons. It would be interesting to learn it. And second, if there were suspicion that this patient had either no QVMI or the occlusion of the stent in the RCA, I want to ask, why not prescribe thrombolysis, especially as coronary angiography had to perform only on the other day, next day? I ask it because these two moments are not quite compatible with my understanding of the strategy of such patients' management. After that, practically everything was within the generally adopted rules. Coronary angiography revealed stent occlusion, recanalization, and after recanalization we had seen a large thrombus, and because there was no angioplasty, I so understand, and the angioplasty, balloon angioplasty, was done only 1 month later. Yeah, I think so. Yeah, it's right. 1 month later was done. Yeah? Okay. Standard pharmacological therapy was prescribed. I would like to make only one additional point. Taking into account that a lot of time elapsed since 2007, since the RCA stenting was performed, and moreover, the stent was closed. Maybe it would be reasonable to implant a modern generation stent, bare-metal or disc, at your choice or at the possibility of your clinic. Especially as the patient is rather young, 63 years old. However, in general, all was done reasonably within the frames of widely spread standards of the treatment of patients with MI. It is my opinion, my vision of treatment this patient in these cases. Thank you very much.
Thank you very much, Professor Iosseliani. And we are moving now to second case, and Dr. Asado will tell us about too early myocardial perfusion in STEMI using combined thrombolytic and mechanical revascularization.
Dear Chairman, colleagues, I would like to present a case on the subject, early myocardial reperfusion in STEMI using combined thrombolytic and endovascular therapy. I do not have any potential conflict of interest. In total, from 1997 to 2016, in the Moscow City Center of Interventional Cardioangiology, we have treated more than 10,000 patients with acute myocardial infarction. Among them, 1973 patients received pre-hospital thrombolytic therapy. In most cases, this therapy was used in patients who, for some reasons, could not be transferred to the hospital within the gold standard interval, 90 minutes from the onset of angina attack. So, a 60-year-old male was brought to the Moscow City Center of Interventional Cardioangiology with anterior STEMI, 180 minutes after the onset of the symptoms. Pre-hospital thrombolytic therapy was done. At 20:30, after alcohol intake, he had the first angina attack in his life. He tried to improve his state with home measures, but these attempts were unsuccessful, and only at 21:30 he called in an ambulance. The emergency team diagnosed the anterior STEMI and relieved pain. Taking into account the delayed call to the ambulance, high Moscow traffic, and eventual loss of time for the preparation of patient for the transfer to the cath lab, primary PCI with the gold standard time became unlikely. So it was decided to use systemic thrombolysis as an alternative method of myocardial reperfusion. The patient had no contraindications for the procedure, and at 22:15, 105 minutes after onset of angina attack, 40 milligrams of metalized were administered intravenously. Also, at pre-hospital stage, the patient received morphine, heparin intravenously, and aspirin. As for risk factors, we can mention smoking, dyslipidemia, and alcohol abuse. The patient did not control his blood pressure or blood glucose previously. He had no angina pain. Primary ECG revealed the acute phase of the anterior STEMI. There was a elevation in the leads V1 to V5 with reciprocal depression at the posterior wall. In 20 minutes after TLT's positive effect was seen in the form of significant ST degrees in the contiguous leads. At admission to the center, the patient had no angina pain and completely only of weakness. His blood pressure was 110 to 70, beat rate was 19 beats per minute. He had rhythmic pulse with rare ventricle extrasystole. Respiration was 18 per minute. The ECG showed a logical decrease and heart rhythm disturbances, probably related to reperfusion. In hospital medical therapy, he got nitroglycerin solution, heparin, clopidogrel, and bisoprolol. Left ventriculography showed dyskinesia of the anteral, lateral, and apical segments. The ejection fraction was 40%. CEG data shows critical stenosis of the proximal segment of LAD, antegrade blood flow TMS3, some diffuse change in the remaining coronary arteries without stenotic lesions, and symptom score was 16. And here is angiographic stents. You can see critical stenosis in the LAD. And some diffuse changes in the remaining coronary artery. Thank you.
So, thank you. Questions? Actually, the look symbolizes it was really effective, and this is it's quite interesting. What do you think about the right coronary artery?
We think that the right coronary artery had no significant lesion, and in the moment of STEMI, we do not treat it.
Okay, more questions?
I think there was no severe but significant stenosis in the right coronary artery. I think so, but not severe.
Yeah, and maybe one, if you remind us, I didn't catch from thrombolysis to angio was what is the time between?
1 hour.
1 hour. It's fantastic. It's really
After admission?
I mean, between thrombolysis and angio.
Yeah.
It's really 1 hour.
Around 1 hour.
Around 1 hour, yeah.
It's very, very quick, yeah. It's really followed by guidelines. Questions, comments? No questions, then ask to Dr. Kumsas what you would do in a case like this one.
So, how would I treat this case? So from current revascularization guidelines regarding management after revascularization, after fibrinolysis, we actually see that in both situations, when thrombolysis is effective, we need transfer patient to cath lab and do angiogram, and with consequent treatment in 3 till 24 hours. And also there is no doubt that if thrombolysis is not effective, we can immediately try to transfer the patient to cath lab and do rescue PCI. So once again, Professor Erglis already showed this logistic slide of STEMI. I just want to show that really in situations where there is not possible to do in two hours primary PCI, or let's say from first medical contact to balloon time, the time is more than 2 hours, you should do fibrinolysis. and afterwards, of course, to transfer patient to primary PCI center. So one of the biggest study which addressed this question, early thrombolysis versus primary PCI, and the patient population was STREAM study, and the patient population was those presenting, STEMI patients presenting with less than 3 hours after symptom onset, and who cannot undergo primary PCI in first hour after medical contact. And there was two groups. One was thrombolysis group and one was PCI group, and a bit later the thrombolysis group was divided in two groups, one with patients less than 75 years and the second group with more than 75 years, using half dose of tenecteplase because there was quite a lot strokes in this old elderly group. If we look on the STREAM study results in primary endpoints at 30 days, there was no difference between both groups. However, there was more strokes and intracranial hemorrhage in thrombolysis group, and based on that, actually in the current revascularization guidelines, experts said that in view of the lack of superior efficacy and increased rate of intracranial hemorrhage, emphasis should remain on timely PCI within STEMI networks as a preferred treatment for STEMI. Of course, there is quite a lot of solid data showing that there is a benefit from early invasive strategy after fibrinolysis. And maybe I would like to bit focus on approach what we should do in such case, especially after thrombolysis. And I think today there is no doubt that the preferred approach is radial accessing. Here we can see a meta-analysis from 4 trials showing a benefit in mortality and MACE and major bleeding using radial approach in acute coronary syndrome. However, there is also interesting data that showing that, I mean, in this population after fibrinolysis, which is particularly, I think, for high risk of bleeding, the usage of radial approach was only 14%, and I would just like to stress that I think it's really important, especially if we are speaking for those patients after fibrinolytic therapy, to use a radial approach. So, my strategy, in this case, I would really stick quite close with the current guidelines. I would use stent, I would use, if possible, new generations drug-eluting stent. I would try to do radial access, and in this case I would not do thrombus aspiration. And just before finishing, I would like to once more stress how important is this timing of reperfusion therapy. These are maybe old data, but showing that 1 year mortality increased by 7.5% for each 30 minutes delay. And I would like to finish with this slide. Do whatever it takes to reduce time from symptom onset to emergency arrival and to primary PCA. I think it's a nice done there.
You really have a nice time. If I can echo 2 questions to you. Maybe details about the picture, but you mentioned, and I guess it's very important, and we see now from so many studies, that actually 2 things. It is, of course, no question that we should do cases like this and understand and just clear. And I mean, it's really no haziness. Especially, Thrombolysis did a fantastic job, and no question. For me, it is the two things. First of all, and you are also responsible for this in our hospital. And this is a question about the transradial approach for acute MI, because it's no question that we use 70 to 80% if possible I mean transradial angio PCI for stable patients. But I'm not sure that we do the same for ST elevation patients. And could you comment on that? And the second thing, why and do you think how we can improve this? And second thing is about zygolutin stents, because there is I guess maybe you can confirm that there's no discussion anymore that we should use zygolutin stent for every subset of intervention. But could you comment on
regarding the radial approach? I think, no, I can say that we are trying to use as much as possible radial approach also in acute patients, because there, of course, there are some cases, maybe different problems, very elderly, or there is bad pulse, of course, but I think it's close to 80%. It is ours, I think.
No, it's no. We fight for this, but
anyway, we have to push more. You are completely right.
My question is, of course, no question if it's in daytime, but is it in 2 or 3 at night? Do we have the same?
Yeah.
What we need actually.
Because, you know,
Gustav, thank you that you are shaking your head, and I really wanted to participate in discussion a bit later, but this is I guess very important point, and we should keep this. We really keep, because it's the difference is huge.
Because you know that I think that a lot of young colleagues now do radial approach better than femoral. That's a bit more joke, but I think
it's not a joke. Actually, it's also it's also is how to say we should you know.
Yeah. And of course, there is no doubts about this usage, and I think also new generation. There's no doubts. Also, if we look in guidelines, we know that only in situations with contraindications. But nowadays, if even we will have, of course, it's not for acute coronary syndrome that we can use only for 1 month.
Yeah, but we should not to mix this.
Yeah,
it would be just for acute coronary syndrome.
But there is quite a lot of evidence showing that this is preferred strategy.
But only one more time, for the acute coronary syndrome, doesn't matter what we used, we should go for dual antiplatelet therapy for 1 year at least. Okay, fine. Okay, next one. Thank you, Indra.
Next one is, please.
Next one was Dr. Smith
Again.
He's an important and big man.
It's not so simple to present my topics after previous speaker, because it was so wide.
You are in consensus, that means, but it's also
No, it's not my purposes. Maybe chairman could make it. Just a second.
Yeah, I guess you are doing very good. Now it's okay.
Yes, it was everything to do. Yeah, I don't know what happened. Well,
Your name is Dimitri.
right. It was 1993 when the world realized that primary angioplasty is better than thrombolysis. But even it was 23 years ago, the thrombolysis is still alive, especially for patients which could not be delivered to the hospital with PCI compatible hospital, or if the team is not so skilled. And if you look at the recommendation, thrombolysis compatible for patient with early myocardial infarction, large arterial myocardial infarction, not longer than 2 hours from onset symptoms, with compromised hyperdynamics, and if expected time for delivery to PCI hospital 1.5 hours or more. That is why this patient was quite good candidate for thrombolysis part. I draw this scheme, this timing for our case, and if you look at the time from first medical contact to the PCI, it's spent 140 minutes. It means that a good decision about thrombolysis in that case, but of course we have to remember about the risk of hemorrhage, bleeding, and some problem with thrombolysis, of course. And then let me look at the medication, the therapy, which was done on pre-hospital and after admission. If we look at the doses of heparin, it's a little bit exciting because, as we know, dose for fractional heparin in patient after thrombolysis should be 60 units per kilogram, or not more than 6,000 for patient. But if we 5,000 on pre-hospital stage, add 50,000, it's amount 20,000. It's a little bit more than recommended, and quite interesting, quite creative approach for the loading dose of clopidogrel. It was 115, opposite the recommended 300, but anyway, everything was good. And the last point, it was absolutely a good result after thrombolysis in 110 minutes with all signs of effectiveness, with written disorders and ST resolution. That is why we can't wait 3